Hello. Yeah, so I'm Dr. Praveen Chandra from Medanta, the Medicity Hospital here in Gurgaon, India. And we are now ready to show you a case who is having a ejection fraction of about 20%. And he has double vessel disease. I'm taking the first shot. So as you can see here, the LAD is 99%. And the OM is a tight lesion, which is also about 99%. It is a left dominant artery. And so we have three issues here. One is that, this is the ostial OM lesion, and we will have to make a strategy where we don't affect the main circumflex artery while we are treating the OM, number one. Number two, this LAD, which is 99%, hopefully we will be able to cross with a softer filter XT wire, and then we will see how it looks. Okay. So we'll use less contrast, and also because this patient also had acute kidney injury prior, which he has recovered from. So we'll do ultra low contrast PCI. So we have only given one shot here today, and most likely we will try to do as little as possible. Right now, he is recovered from the kidney injury. His creatinine is 1 gram %, which is fine. Okay. Okay. His age is 60 years, and presently he is not in failure, but his EF is very low. So here I am with the Fielder XT wire. So let's try and see. His right coronary is diminutive, so nothing. Okay, come to epicranial, please. And his pressures are borderline. So I think he's slightly dehydrated right now. So we will give some little saline. Don't inject too much. So we have entered into one of the septals now. And I will not inject too much while we are trying to cross it. So it seems that we are probably in the LAD now. And no, this is a diagonal. So we are in the LAD now.
1.5 10.
No, not 10. Maybe we can take a 2 into 15 or 20. 2, 15 or 20. Okay. So we have crossed this LAD, total occlusion, with a Fielder XT wire. And as I told you, we will not be injecting too much. So let us see. Can you show the first shot, please? So we'll. Okay. So what we can do is we can go to the ariocaudal projection again, and then based on the calcific, these markers, we can decide the position of the balloon to start with. So in a ultra low contrast PCI, when creatinine is an issue and also EF is an issue, so you don't want to inject too much of contrast. So we will have to use these markers as landmarks. So this is a 2 millimeter balloon, which is crossed now, 2 into 20 and 15, 2 into 15. Okay. Go up, please. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Deflate. So I'll do serial dilatations. Go up. 2, 4, 6, 8, 10, 12, 14, 16, 18. Deflate. Deflate. Go up. 2, 4, 6, 8,
तुम्हारी आवाज आ रही है
10, 12, 14, 16. Deflate.
तुम्हारी आवाज आ रही है
Go up. 2, 4, 6, 8, 10, 12, 14, 16. Deflate. 2, 4, 6, 8. Deflate. So we have done serial dilatations, as you can see in this LAD. And now I'm going to do some imaging to see how long the stent has to be. This was a 2 into 15. At this stage, we can give some little bit of dash of nitroglycerin. Hold this balloon. Nitro. Give some nitro, please. So in patients who have, underfilled arteries to start with, once we have done the dilatation, it is always better to do a nitro. So you're giving some nitro?
yes
Okay.
removing the dye first
Give the nitro. Okay. Okay, fine. So the ECG is okay. The hemodynamics seems to be okay as of now. And I will do the imaging. Okay. Okay, this is the left main, so you can. So the disease is right from the ostium, you can see. So can you see the IVUS? So I'm just entering into the LAD, and this is diseased right from there. And it's a very heavy, plaque burden. And you can also see the
calcium also
calcium, but we will manage. Yeah, so we'll have to do some more dilatation, it seems. Yeah, here also it is disease. Okay, so my catheter is crossed now. Okay, so this is the portion which is actually okay. So now I will do one thing. Okay, show me the epicranial position and give some saline, please. Give some saline. So here it is. So we can see that we have to go all the way below, and I'm pulling back.
NORAD 3
Yeah. So this is
saline and NORAD.
So we'll have to take a 2.5 long stent, and maybe before that we can do a dilatation with a 2.5 balloon.
2.5
Okay, 2.5.
you want to exchange the wire
Not really. We can still continue on this one. Not necessary. Okay. So sometimes, as he is discussing, Abhinav, is that, if we need to change the wire, but since it is a straight segment, it's working out okay. So we don't need to really exchange the wire. And this is a 2.5. I'm doing this dilatation because we already saw some calcific patches. So it's better to pre-dilate better because the stent passage will then be smoother. Okay. Go up. 2, 4, 6, 8, 10, 12.
slip
Deflate. So you saw that because of the calcium, the balloon actually jumped down. Go up. 2, 4, 6, 8, 10, 12, 14, 16, 18, 20. Okay. Deflate. 20. Deflate. So we are pre-dilating well so that we prepare the lesion bed. Go up to 4, 6, 8, 10, 12.
Mr.
14,
Norred 3
16, 18, 20. Deflate. Go up. 2, 4, 6, 8, 10, 12. Deflate. 2, 4, 6, 8, 10, 12. 14, 16, 18. Deflate. Come to RO caudal position. Go up. 2, 4, 6, 8, 10, 12, 14, 16, 18, 20. Deflate. Okay. So I think we are reasonably well dilated the lesion. And now the issue is that we have to treat the OM, and the stent which we are going to put in the LAD
ostium.
is going to be from the ostium. So I will treat the LAD lesion now a little later because I have to put the stent from the ostium. So
BMW.
I'll keep it here and take another BMW to treat my OM. Okay. And in the meantime, we'll just keep the wire in the LAD. So this is very important. So that the passage of balloon wires, etc., in the OM will not be affected. So here we are. So this is a BMW wire which I am taking, and yeah. So this is a low ejection fraction patient without any hemodynamic support. Okay, so it is not necessary, because if I do impella, let me just if I do impella in this case, it will be a good idea. But the problem is that cost of impella is prohibitive in this particular patient. It is not possible. An intra-aortic balloon pump I would have used as a standby, but it is not available these days as it is out of stock in the country. Okay. So we have to check now. Check, please. Check. Yeah. So this is a very tight lesion.
Maybe some balloon support.
Oh. No.
Now we can exchange this with filter.
Maybe. Give me a balloon, please. Give me a balloon.
Same 1.
Same, that one we had. 2 millimeter. So we'll use a support of the balloon because it is a very tight lesion with some tortuosity. However, in case I'm not able to cross it, then I can take another wire, which is the other filter wire. I'm not doing this exchange because I don't really want to give too much of contrast while doing all this. So otherwise I would have changed the wire. Okay. Okay. Talker, please. Connect, please. Connect.
Negative.
The wire needs to be bent a little bit because it is not entering. So I will give a slightly bend to this wire because it has become straightened after some usage. Okay, so here is the balloon which is out. I'm taking the wire out as of now. Pressures are okay. So the wire had become straightened. I'll just give a bend. because then it will be easier to enter in this inside the artery. Okay, so this bend should help enter into the OM. Do you have a 1.2 balloon?
Yes.
1.2. Okay, talker, please. Talker. So the same BMW wire, I have given a little bit, bigger bend to enter inside this branch. Okay, give me a balloon.
1.2. Chota. Small.
Yeah, give it to me. So for a support, I'm taking a small balloon, which will also help me in once the wire is crossed to pre-dilate this lesion. This is a 1.25 into 10 Artemis. Okay. It is not giving any. Epicaudal, little bit. Epicaudal. Okay, just that way. Okay.
Small check.
No, not yet. Actually, there are two bends over there. You can check now. Yeah. We might have to change the wire. Give me a builder.
XT.
Or else what I can do is, let me do one thing.
Exchange
I'll
with that.
exchange it with the other one. In case easily it is possible. Otherwise, we'll take another one. Okay. So this is, hold this. There's a 1.2 and give me a talker. Okay. So now I am going to take the same wire and enter into the LED. As I told you earlier, that because of the dilatation, sometimes, these wires try to enter into the false channels, the dissected planes. Can we show it now?
Epicranial.
Okay, epicranial. So the wire has entered into the main vessel and looks good to me. Okay, it has entered into the branch. Okay. Okay. So we are in the LED now. And they will remove this stalker and take this wire out. This is a Fielder XT wire, and I'll give a bigger bend now. Just try and see if it enters easily. Okay, so this is the same Fielder XT wire.
Or you want Corsair support?
No, I think we'll try the
balloon
support because it's not such a CTO or something like that. Okay. So this wire is not in the best of health, but we'll try. Actually, this lesion is very eccentric. And yeah, now we have crossed. Okay. So you saw that, changing the wire actually just helped to cross this lesion faster. And now we will pre-dilate with a 1.2 followed by a 2 millimeter balloon. Okay.
2.5 ox cutting. 2.5 ox
Now,
cutting.
okay. So we have taken this 1.2 millimeter balloon, which I'm going to use for the pre-dilatation first. Went in easily. Check, please. Check. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Deflate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we are pre-dilating this OM lesion with a 1.2 deflate, please. And then now the plan is to use a cutting balloon to give a good dilatation to this vessel, and then use a drug-eluting balloon because of two reasons. One, that this artery is having osteal disease, and the second is that if you put a stent, then it can sometimes hang into the circumflex main artery, which is the only artery which is flowing nicely unnecessarily. We don't want to disturb that.
Sir, wire X.
Wire, please. Wire is okay. Wire is okay.
Negative. Balloon. 2.5.
So this is a 2 millimeter balloon.
Yes.
Okay, go up, please. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Deflate. Can you check now? Little bit of check. Okay. So we have seen that there is another lesion down below, which we will have to dilate as well. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Deflate. So now at this stage, we will do an IVUS to see if the vessel is needing a 2.5 or a 2.75 Wolverine cutting balloon. And that's how we are going to proceed. Okay.
इसको prepare करना.
Just a minute. Okay. So hold the wire, please. Holding?
Yes.
Okay. Okay. So we are now proceeding with the IVUS. Okay. This is the tight segment there.
Oh,
Okay. It is just stuck at this point. Okay. The IVUS is not moving forward. But the vessel we can measure, I think it looks like a 2.75 or maybe a 3. 2.75 will be fine. Yeah, this is the vessel. Okay. And here also there is a disease. So this is the ostium. So right from the ostium, okay. And this is looking like almost like a 1, 2, 3 millimeter vessel. Okay. Yeah. So give us a cutting balloon, Wolverine.
2.5 is there. You want 3?
No, I think we'll need a bigger one. Show me the last shot.
P15.
Show me the last. Yeah, this looks like quite good. Maybe 2.75.
Not a good. Only 3 and 2.5.
Okay. Because the vessel is definitely distally how much it is? About 2.8 to 3. Okay. I would have preferred a 2.75. You have a 2.75?
In N,
Yeah.
N by 2.7.
Yeah. 2.75, 10 or 15.
Yes.
Yeah, that'll be better. Yeah. 2.75, 10.
So meanwhile, can you tell, sir, how can we prevent the intertwining of these wires if there are two wires?
Yeah, basically, you have to, the basics principle is to keep the wires separate, let them not intermingle outside. If they
Okay.
are not intermingling outside, they are not, intermingle inside as well. And also that while you are crossing, once the first wire is there, the second wire should be taken without too much of movement.
Okay.
Okay.
And if it is the intertwining is there, then we can use a balloon support to just.
Just yeah, clear the intertwine. Okay. Can you check now? Where are we? You have to check. Check, please. No. I have to go a little bit more. Yeah, now it has crossed.
This is
Check,
the point.
please. Yeah. Little bit, yeah. Okay. Go up. 2, 4, 6, 8. Yeah, this is the lesion. You see? 8, 10, yeah, 12. It is gone. Now the lesion is gone. It was a calcified plaque. So we are using a cutting balloon Wolverine 2.75 into 10, going up to 12 atmospheres. And at 12, it is size should be about 2.9 or something like that, which is good. Okay, deflate. Check, please. Where are we? Okay. Okay, now go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. 12, 14. Deflate. So we go to reasonably high pressures, and at 12 it was almost about 3. So this is, we have achieved a good size of 3. And just AP caudal, please. AP caudal. I want to check whether we have, cut the ostium or not. Okay, I throw a little bit LO. That's fine. Okay. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Okay. Deflate. So here we are done. We can do some more dilatation in the distal segment. Yeah. Okay, please. Deflate. Okay, fine. All right. Okay, we can check now.
Excellent. Oh, IVUS for check.
We can check also a little bit. Okay. Oh, that looks nice. So this artery looks reasonably big, and we can do an IVUS. So you can see that, there is a plaque at
Ostium.
that bifurcation point, but we are not touching it, and otherwise we'll have to put 2 stents there, and doing a bifurcation I don't think is a great idea. Okay, so I will do IVUS again to see how the vessel is looking, and At the moment, I think it's looking good. There is no major dissection, nothing. And we will see on IVUS how it looks. Okay. So you can see that the IVUS has crossed so easily now. And vessel is about 2.5 distally, and here it is about 2.75. Okay, and you can see the cuts. Yeah, the cuts are very visible, and this is also very well dilated here. At the ostium, we can do a little bit more. Okay, but still it is, I think, fine. We can do some dilatation again using a 3 millimeter. At the ostium, we can use a 3 millimeter cutting balloon. But distally, it is okay. Proximally, we can do a little bit more. Okay. So I'm using a 3x10 Wolverine. So the intention is to not put a stent there and get as best as possible outcome here.
Inflated ones.
Inflate it. Inflate. Okay. Okay. Deflate. Okay. So here it comes so easily. Okay, you can check now. Okay. Yeah. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8.
We'll take some. We'll pull it back slightly.
9. It's okay. Deflate. Check. Yeah, it's okay. Go up. 1, 2, 3, 4. Store it. 5, 6, 7, 8. 9, 10, 12. Okay. Deflate. So we are now, I think, fully done with this lesion. Show me the last stored fluoro. So this is a 15. 18 might also do the job. Or maybe we can take a 26 will be better,
yes,
because then it won't miss anything. Okay, so let's take a 26.
2.75?
2.75, 26. Sirolimus eluting balloon. And then we'll see how it goes. Okay. So whenever we are doing, these kind of osteal lesions and long lesions, we always try to do and get a optimal outcome with balloon angioplasty first, and then only proceed with the drug balloon part. So that will be the last part. And this is a sirolimus eluting balloon, which is now going inside here. Okay. Okay, we are in position. Janek, please. And we can check now. Check, please. Oh, this is perfect, actually. 2.75 into 25 is perfect. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9. So we have gone up to 9 atmospheres, and we will stay there for about 1 to 2 minutes.
So
if the
meanwhile, you
patient
can
tolerates.
You
Yeah.
can just tell when,
Uh,
like the balloon preparation, this drug-eluting balloon should be prepared inside.
balloon, generally
Otherwise,
don't. Otherwise, sometimes it can deflate, inflate outside. So we take the device inside and then only we connect it to the, yeah. So we can see pressures are about 70, 80 because, we have
terminal
dilated this
1 ml.
and we will support him a little bit hemodynamically for maybe 30 more seconds because he won't tolerate too much. And
0.5.
0.5 and then we'll deflate. So minimum, if we can do it for 1 minute, it is best. Otherwise, we typically try to do it for 2 minutes, 1.5 to 2 minutes. And this is about 1 minute now. We will,
Fluid though.
okay. He is okay. He has no pain, nothing. ECG is also stable. Okay. Deflate. I don't think he will tolerate too much, so we'll take it out. Okay. Okay. PP is getting better.
ACT.
Just wait for a few seconds. So after this dilatation, which was for about 1 minute, about 20 seconds, and we have now deflated the balloon, the ECG is okay. The blood pressure is also picking up. It's about 85, 90. Patient is absolutely comfortable and he is fine. Okay. Maybe we can check now. His pressure is 100. This looks nice. I think we have got a good result on this osteal OM, and now we will see about this LAD. Okay, so let's have the LAD stent, please.
You want to take that 61?
Yeah, maybe we can take a 60. Yeah, we can take a 60 millimeter long stent. However, let us see if, yeah, I think 60 should be fine. So we have a tapered stent which goes from 3 to 2.25. So 3 2.25. Yeah, it's okay. Yeah. It's a tapered stent from Merrill, and this is the BioMine tapered stent, and this is the longest stent we have. And this is tapering from approximately 2.75 to 3 and distally 2.25. Okay.
Apparent 1000.
So how much is the SCT?
Running, sir.
Running. It's running right now. Okay. Okay. So now the stent is in the LAD. Goes very easily up till now. And we can check a little bit. Check. No. Okay.
Yes.
Check, please. Looks okay.
Half dot, right?
I think just a little half dot outside. Check, please.
Yes.
I think we are fine. Check, please. Check a little bit more. Yeah, okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay. So this is a 2.75
2.75, 2.25.
tapering to 2.25, and the stent is fully dilated now. Epicranial. Okay. Yeah. So stent looks quite expanded. Deflate, please. And let it deflate because it takes a little time. Okay. Right. So this was a 2.75, 2.25 tapered stent, biomime, and now I will not maybe do a IVUS. What is this?
2.5.
No, so let's do an IVUS first to see whether we need to put one more stent distally or is it done. I mean, we are not injecting too much contrast because we are already done about 40 ml contrast. We don't want to exceed too much. How much is the GFR of the patient?
38.
3840.
Yes.
And the best thing is that we have to keep the patient hydrated. Of course, keeping an eye that he doesn't go into failure because he has low EF. Okay. So the vessel is quite thin because of this underperfusion. It's a infarcted vessel largely, but there was some hibernation. So the stent is in good position. And distally, we don't have to dilate, do anything. Yeah. Yeah. Good. So we can do some dilatations here. Yeah. With a 2.5, and then proximally here we can do with a 3 or a 3.5. Okay. Yeah. So the location, stent is well positioned. Okay. So we were able to, do the whole long lesion with just one stent, which, cuts down the cost, which cuts down the possibility of overlap or miss. Because sometimes it can be a big overlap, sometimes it can be a miss. Okay. Stent boost. So we can see the stent boost, which is the online stent boost on the Volcano system here. Go up 2, 4, 6, 8, 9, 10, 12. Deflate. Okay. 12, 14, 16. Okay. 18. Deflate. 18, 20. 20. Deflate. 18, 20. Deflate. 20. 22. Deflate. So we have post-dilated this stent with a 2.5 going up to high pressures distally. And now we'll take a 3 millimeter balloon. So the expansion limits of the stent is quite nice. And we are already not exceeding its expansion limits. So the wedges, catheter is slightly wedging. I'll take it out. Yeah, it's okay. Yeah. So this is a 3 millimeter high pressure balloon. Yeah. Okay.
ठीक है sir.
Check please. Check this balloon. Go up, deflate. Okay. So we are ready with this. Okay, okay. From here. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Deflate. 14, 16. 14, 16. Deflate. 14, 16. Deflate. 14, 16, 18. Yes. Deflate. 14, 16. Deflate. The stent is dilated. Position is okay. Check.
Are you
Yeah, it looks okay. Go up. Go up. 1 minute. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 16, 18, 20. Deflate. Okay, fine. Okay.
Yes.
So we are now okay in the middle, just beyond the ostium. Go up. 2, 4, 6, 8, 10, 12, 14, 16, 18. Deflate. Okay. So we will now check and make a. Shall we give some? No, not really. Check, please. So we can see that this OM is flowing well. There is a small linear flap, but nothing to worry. And the LED is also very well opened up, and the distal vessel is also now filling up. I think gradually this will increase in size in distally also, and so we are pretty much done on this artery. Yeah, just a minute. Okay, I will take this out. Okay. Okay. So we are done with this. And last shot, please. Shall we take one more shot? Not necessary. I don't think it's necessary because we have already done about 48 ml of contrast.
Just to see whether this OM is still.
I think this OM is flowing very well. And this small, dissection, which is a type A dissection, it will heal and it should not be a problem. And this main circuit is also very well preserved. The flow is TIMI 3 already, and no recoil. Yeah. Okay. So we'll stop here. Thank you very much, and hope to see you all again in the afternoon at about 4:30 India time. All the best. Thank you.